you have this fundamental technique, you're familiar with it, you go in the long tube, you hear a lot of knocking, takes a long time, you have to stay still. So, I mean, which has a lot, I mean, you have to consider that piece when you're thinking about how would we use this as an assay. It's not simply, you know, just let's request that lab test. It means someone has to go in that magnet and lay there for a long time, perhaps be claustrophobic, perhaps not fit, lots of things that can really limit how well we can really use something like that as an assay. But again, within MRI, you have the ability to sensitize that signal that produces the image. You can sensitize different properties of the tissue. The fundamental property is something called T1 and T2. These are natural properties of water molecules that have to do with how quickly they respond to the magnetic field and how quickly they restore equilibrium after you turn the magnetic field on. This basic property, it creates contrast in the image because those are tissue-specific behaviors. So that's at the heart of MRI. We can inject a contrast agent and do something called contrast-enhanced MRI. We use that in breast cancer. It's actually, you must use a contrast agent when you perform MRI to detect breast cancer. Then there are techniques where you can weight it to water diffusion. You can weight it, you can look at, we look at the most, the highest concentration proton species, which is in fat and water tissue, so that we can get that high anatomic detail. But you can also tune in to other protein-containing metabolites or other nuclei that you can make MRI sensitive to. Then the concentrations of those metabolites are much smaller. They're harder to detect. Image quality goes down. Resolution goes down. So you take that hit. So usually we do those. We do the standard water lipid MRI so that we can get a nice crisp anatomic imaging, and then we add other techniques. Near-infrared optical imaging, it's something that people have been looking at forever, but it's actually a technology that now is, I think, advanced enough that we can start to think of it in a practical way. And positron emission tomography is also another very exciting technique used a lot now in oncology, and it basically has while the spatial resolution is not great, what it does do is you are looking at specific molecular targets, so you can be much more specific about what you're seeing in the image. I think I'm actually, in the interest of time, going to go past this, but there are ways to quantify, even with digital X-ray, to take ways of normalizing the signal, either with an external or internal reference, and get a quantitative value out of a mammogram. And that is one way we know that density can predict for risk. There are ways now to retrofit these instruments and develop software so that we can actually extract numeric data from digital mammograms. And that's work by John Shepard, the slide that I just showed. He's here at UCSF. And then there are the 3D techniques. These are very exciting. Some of these images, technologies look very, the resolution is superior to digital, full-field digital mammography, but these instrumentations are not fully developed, the technology of them. They're really not fully developed. And they suffer from a few problems that engineers are trying to address right now, and we may see them come into fruition. But for one, in the tomosynthesis systems, they found that there could be reduced sensitivity to calcification, so it's not quite performing at the level of digital mammo. Also with the CT approaches, it's difficult to build that instrumentation so that you can see the chest wall and axilla very clearly. MRI, as I mentioned, it has a clinical role in primary breast cancer, and you must use it with a gadolinium contrast agent in order to enhance the cancers and to identify them relative to background. It's already established itself as being more effective than the existing methods to demonstrate the extent of cancer in the breast. What we don't know is that has led to improved surgical outcomes. If anything, it may have been, what we're seeing right now is that what it's leading to is an escalation of surgical management as opposed to more appropriate and more well-defined surgical management. And then the advanced techniques that I mentioned. So I mentioned these in particular. So these are layered onto the anatomical imaging that we get from MRI. And the three major techniques that we use are the dynamic contrast enhanced MRI. So the patient's in the magnet, we take images, we inject contrast agent, we look for a blush or an enhancement in areas, and the more that you see right after the injection, the more suspicious that area is for cancer, and it can show you, demonstrate the cancer very nicely as a picture. But there's actually a time course of that pattern of enhancement, and if you image fast enough, you can start to look at what that signal enhancement time course is. And from that, it's basically tracer kinetics. You can extract from that signal intensity curve the values of the flux of contrast in and out of tissue. And so you can apply models to the imaging data, and you can extract quantities that have to do with the pharmacokinetics of the contrast agent, and those should be reflective of properties of the tissue, like the permeability and the blood volume. Diffusion-weighted imaging is a fairly easy technique to implement, but it does lead to image degradation. It doesn't involve a contrast agent, and what you're doing really is sensitizing the signal to free motion of water, and so you can calibrate that so you're actually sensitive to the random motion of water, and if the water is experiencing boundaries, like cellular boundaries, then you'll see that reflected in the diffusion coefficient. So we can measure that in vivo and anatomically, and that can also give us a sense of the cellularity of tissue, and if we're using drug treatment, what the change in cellularity that results. And then MR spectroscopy is a much more technically complex approach. It's used a lot in the brain and the prostate. It's very challenging in the breast. I'll say a little more about it, but essentially lets you look at a protein-containing metabolite other than water or lipid. In this case, choline, which is associated with cell membrane synthesis and proliferation. So again, it's a potential marker. Okay, as I mentioned, the DCE MRI, just briefly, you would take a sequence of pictures after injecting contrast, and then you can go at any point, draw a small region at any point, and you can map out the signal intensity change over time. The technical requirements for this are a little at odds with what you want to do for the clinical use of breast MRI. So you need to be in the 10-second temporal resolution, which means you have to keep reacquiring the data over and over again very rapidly. By reducing the time you spend acquiring the image, you actually you have to give up something like the coverage or the resolution or the ability to use something we call fat suppression to make a kind of a sharper picture of tissue. So all of these things have to be compromised. You also have to make some additional measurements that have to go into the model. So there are some complexities to really pushing contrast-enhanced MRI of the breast to the point where it is a physiologically based measurement that you're making. So that has implications for, again, how we can apply it. Diffusion imaging, this is a standard what we call T1 weighted anatomic imaging after we've given contrast, and you can see what I've been referring to as an enhancement or a blush, and that's on that basis the radiologist will make a diagnosis and size the tumor and describe it otherwise. The same patient in the magnet, if you've been in MRI magnets, you know that you'll hear knocking for several minutes at a time, then there'll be some quiet time, it'll start up again, a new sequence. We're running a new sequence. So we would run this exam, and then we would run one for diffusion. The diffusion images are much less quality images, and from there we take a sequence of them, which I actually, I think this one. So here's the T1 weighted image at the standard with the contrast, and then we run another sequence where we've weighted with the gradients to different levels of diffusion, and then we calculate on a pixel by pixel basis, same pixel here and same in this one, the diffusion coefficient, and this is a mapping then of that number. So this is called an ADC map, but it does tell you something. It tells you something from a biology. The property is different than what we're learning here. This is reflective of vascularity, and the diffusion coefficient is more reflective of the cellularity of the tumor. And in there's a number of published studies that people that have applied diffusion-weighted imaging in the breast, but essentially what you see is that the ADC value, this is actually in response to treatment, you'll see that the values in tumors go up with chemotherapy treatment and actually go down in normal tissue, get a buildup of fibrosis and actually increase cellularity density of cells in treated tissue that is reflected in the ADC. So it can be, presumably be used as a marker